Right. Welcome to our GW University Seminar Series hosted by the GW Institute for Brain Health and Dementia, entitled Addressing Dementia Across the Public Health Spectrum. This series brings together researchers to discuss the multitude of issues surrounding the area of cognitive health and dementia. I'm excited to introduce our speaker today. Dr. Jaclyn Stephens is an assistant professor of occupational therapy at Colorado State University. Her research is focused on evaluating adolescents and adults with sports-related concussion and more severe forms of traumatic brain injury using behavioral measures and neuroimaging techniques like EEG, functional near-infrared spectroscopy, and functional magnetic resonance imaging. Specifically, she seeks to better understand the neural physiology of head injury, create innovative behavioral measures for return to play evaluations, and evaluate brain behavior changes that are elicited from interventions like yoga. So I'm pleased to introduce her title of Yoga Improves Balance, Mobility, and Return to Occupations. Thanks, Dr. Stephens, and please take it away.
Thank you so much. And thank you all for inviting me to speak today. I know that this series is on, dementia and cognitive health overall. But as we go through this, we'll start talking about a population, individuals with brain injury who do tend to have some risk factors related to later cognitive impairment and overall difficulties with brain health. So the focus of this is certainly on what the title indicates, Yoga Improves Balance, Mobility, and Return to Occupations, but we certainly have measures and intentions for this work that are much broader than what you see listed in the title. So I'll get to speak to all of that today. So just as a note, as I'm speaking, please feel free to interrupt me if you have clarification questions. I'm happy to be interrupted mid slide. Otherwise, I've also put slide numbers at the bottom of each of my slides. So if it's easier for you to just jot down what slide you'd like me to return to, I will have a question and answer session at the end. So, all right, go. Get my slides to advance. There we go. All right. So today what I'm going to do is just start with a little bit of my background. I had a somewhat unusual training path that brought me to a tenure track faculty position, and I like to share that particularly when there are students in the audience. I'm going to speak a little bit about my primary population of interest. So I've alluded to this as folks with traumatic brain injury. I know there are a number of people in the audience who have a lot of expertise with this population, and then maybe for some folks it's a newer population. So I'll spend a little time on that. I'll talk about how I leverage neuroimaging in traumatic brain injury research to answer some what I think are important and interesting questions. And then I'll talk about how I've been integrating my occupational therapy background with my burgeoning expertise in traumatic brain injury and neuroimaging. To do that, I'm going to share 3 example studies, all along the same vein of using yoga for folks with brain injury. I'm going to share some lessons that we've learned along the way and some future aspirations that I have for myself, my team, and this work. And then, of course, we'll have time for question and answer. But again, feel free to interrupt me at any point if something I say is unclear. We're spanning a lot of different fields, a lot of different contexts. So if anything is confusing, let me know. All right, so a little bit about me. I started with with training in undergrad in psychology. So I was a psychology major. I really had ambitions of finding a path that would allow me to have some clinical work, some research opportunity, and some teaching opportunity. And I thought clinical psychology was going to be the right avenue for me. And while I was in my undergrad, I was introduced to occupational therapy. And occupational therapists also, especially those of us working in research institutes, have this like clinical research teaching kind of integration in what we do. So I ended up doing what was called a 3-2 program, where I did 3 years of my undergrad at Illinois Wesleyan University, and then transitioned to Washington University School of Medicine, where I got my master's degree in occupational therapy. So after those 5 years, I actually had the opportunity, and this isn't depicted here, but I had the opportunity to live and work overseas. So I worked at Dubai Center for Special Needs with adolescents and young adults with developmental disabilities in the United Arab Emirates. I was there for 2 years, and when it was time to think about coming back to the United States, I started applying to PhD programs. And at the time, there weren't a lot of PhD programs within occupational therapy departments. So as an example, at CSU, where I'm situated right now, our PhD program started in 2013. The year I was looking for PhD programs was 2010. And so there weren't a lot of opportunities within occupational therapy. So I ended up returning to my home of psychology and ended up working in a memory and brain lab. And so my PhD and my PhD training is actually in experimental psychology with an emphasis in cognitive neuroscience. So I have a clinical degree in occupational therapy and a research degree in cognitive neuroscience. While I was working on my PhD, and actually throughout my postdoc as well, I was working every Saturday in clinical settings with folks with brain injury. So I got my certification as a certified brain injury specialist, and I worked with people with brain injury as depicted here on returning to important occupations, things that they did to occupy their time. So if we don't have the OT language down, occupation is a little misleading because people think work. So I like to define that occupations are anything that people do to occupy their time. So we work with kiddos all the way up to older adults, and we help them with anything and everything like you see depicted here, cooking, that they do to occupy their time. So really meaningful activities. So I was working clinically as an occupational therapist while doing my research training. And this lent itself nicely to the postdoctoral opportunity that I was given at Kennedy Krieger Institute, which is affiliated with Johns Hopkins School of Medicine, where I worked in the Brain Injury Clinical Research Center. And I primarily worked in a population of pediatric traumatic brain injury. So my primary population is adults and youth with traumatic brain injuries. So we were a pediatric lab. We were working with kiddos 13 to 17. My clinical work was more with adults. So my research focus is kind of along that spectrum. So adolescents, young adults, and adults with traumatic brain injury. And just briefly, so that we're all on the same page, traumatic brain injury is defined as an injury that occurs from an external force that causes a rapid acceleration and deceleration of the brain within the skull, causing structural and physiological damage. This is different from brain injuries caused by lack of oxygen or bleeding like stroke. So traumatic brain injury is really that external force piece, is that definitive component that distinguishes it from other types of brain injury. There's some estimates about the incidence of TBI in the United States. So the Center for Disease Control said that, roughly 200,000 hospitalizations from TBI happen each year. About 65,000 people die from traumatic brain injury each year. And it's thought that about 5.3 million Americans are living with TBI-related disability. So when we're talking about those populations, the hospitalization and the death and folks with disability, we're typically talking about moderate and severe types of brain injury. So really, really obvious overt deficits that originate from that external force, that origin of injury. But what's really interesting about TBI is that depending on who you ask, you tend to get statistics like this, where you can see, and I'm sorry that the font is a little small here, but you can see that this largest portion of the pie is mild brain injury. So these are statistics from the Agency for Healthcare Research and Quality. If you see CDC estimates, you typically see anywhere between 80–89% of traumatic brain injuries that are sustained are mild. Those are not the folks often ending up hospitalized. They might go to the ER to rule out something more severe, but these are folks that are getting injured, getting hit in the head. You hear concussion. So concussion is a type of traumatic brain injury, and it falls into that mild category. So while I was doing my postdoc, even though I was at Johns Hopkins and we had a large brain injury unit, most of the kids that came in, fortunately, were sustaining mild injuries. And this shifted our focus quite a bit to thinking about this population and allowed me to transition my work from my postdoc at Johns Hopkins to Colorado State University with a focus on sports-related concussion. So again, sports-related concussion is a form of mild traumatic brain injury. It's the most common type of brain injury. And I actually have a K award, a career development award from the National Institute of Health focusing on sports-related concussion. And I'll say more about that towards the end of this presentation. But I typically think of all my work as kind of falling under this brain injury umbrella as my primary population. When I'm evaluating this population, I use a number of tools. So like most people working with people with brain injury, particularly as a clinician, we're using self-report measures. We're using assessments of motor performance, like how well can you balance on one foot? And we're using various cognitive tests. So we're using these things to assess behavioral performance. So if you kind of lump all those things together, self-report and balance and things like that, you might be thinking of that as behavioral. And that's kind of how I distinguish some of the work I do: behavioral, including self-report, and then neuroimaging. And so what neuroimaging allows us to do is kind of get at some of the nuances or get into some of the more mechanistic pieces that are contributing to some of the behavioral deficits that we're seeing. It also tends to be a little bit more sensitive than behavioral measures at detecting really subtle deficits. So in general, we use lots of different, my collaborators and I, my mentors and I, we use a lot of different neuroimaging techniques. So in the introduction, it was mentioned that I use electroencephalography to measure brain activity with really precise temporal specificity. So we know when the brain activity is happening. I also use two other neuroimaging techniques. I'll say more about both of these in a moment. But functional near-infrared spectroscopy and magnetic resonance imaging to kind of look more precisely where brain activity is happening. So we can look at specific structures during tasks, or as is more depicted here, we can look at things like how well is the brain connected functionally and structurally. So we know that certain brain regions are responsible for certain behaviors, but we also know it's not quite that simplistic. It's networks of brain regions working together to generate things like motor behavior or language or our memory. And so we also think about how the brain is functionally connected. So what regions of the brain are working together in a functional way, those are our networks. And then structurally, we think about how the white matter tracks, how the regions of the brain are structurally connected to each other. So think highways on a road, how are they structurally connected? So we look at all of these different types of pieces of information. And what I have done in my career is used all of the techniques, which means at times I feel like I'm a dilettante in everything and I know nothing about anything very well, but it also allows me to ask the right question with the right tool, rather than getting too focused on really understanding how one specific tool works and all the perfect ways to acquire those data. I collaborate with people who do that so that we can leverage their expertise. So everything I'm going to be describing from here on out is a team science approach. And so it's just kind of a way that I have shaped the work that I'm doing so that I continue to answer good questions and don't get stuck by methodological limitations that I maybe don't have all of the expertise necessary to execute. But all in all, we've been using neuroimaging to answer some of our more impactful questions. All right, so together, what this has meant is that I have tried to figure out a way to integrate this clinical expertise that I have, this occupational therapy lens where I'm really concerned about people getting back to things that matter to them, and understanding this population of folks with traumatic brain injury and all of these neuroimaging pieces. And sometimes these feel like they're on opposite sides of a spectrum, but sometimes I can integrate them together. And I've been really focused over the last few years of saying, what can I add to the field of traumatic brain injury? How can I take these different training opportunities that I've had, these different experiences that I've had, to add something unique and meaningful to the field of traumatic brain injury? So I've done a lot of work evaluating the population of folks with brain injury. So just as a strict what's happening, descriptive of what's happening as a result of the injury. But more recently, I've been partnering with interventionists and saying what happens as a result of an intervention. So we understand that this population has some limitations, and we want to see if we can improve those. So I'm going to give you those 3 study examples where we have tried to do just that. So the first study is yoga for balance, mobility, and occupational performance. And as you probably know from the title, you know what's going to happen here. You know that yoga will improve these things because we've already told you that they do. But this was the foundational study. This is a really important study just to get this work started. This was a collaboration with Dr. Arlene Schmid and Marika van Pembroek, who are yoga intervention experts. If you don't believe me, they have actually written the book on this. So there's their book. And they have actually written a book of yoga therapy for stroke. So alongside of developing a yoga program for folks with stroke, they started to test the yoga therapy protocol in a new population, so adults with brain injury. So this is including people with traumatic brain injury. Now, as many of you probably are aware, there's some overlaps between traumatic brain injury and stroke, particularly when you look at the deficits that people are experiencing, mobility deficits, balance deficits, things like that. So it makes sense to take something that worked in a similar neurological population and apply it to a new population. So that's exactly what they did. And my role in this study, I came in late. So my role was to take the results that they had gotten from a study that they conducted before I got to CSU and write the manuscript. So if we have any early career folks in the audience, one of the things that happens when you start a new faculty position is you get your lab up and running and you're getting your equipment and you're learning how to use it and you're trying to connect with people so you can recruit your population and you don't have a lot of data. So Arlene was kind enough to say, I have a lot of data and not a lot of time, and you have expertise in traumatic brain injury. So take these results that I generated that I don't really have time to work with right now and write them up, and you write the first draft of the manuscript and we'll get it out there. So I was really fortunate to be able to work with her and take the data that she had collected in one of her studies and disseminate it. And this is kind of what got us started with our initial collaboration. I'm going to share a little bit about the methods of this study, even though I've already told you what the outcomes are, just so that you're aware of kind of what we're working with here at Colorado State. The methods for this study and the following studies will be quite similar. So our data collection and our yoga intervention were completed at a university-based research lab. The design for this first study was a pilot non-randomized crossover trial. So participants served as their own controls, where outcome measures were administered at 3 time points. So essentially, people were evaluated at a baseline, then they had an 8-week no contact period, and then that was before yoga started. So they were evaluated again immediately before yoga and immediately after yoga, so that they served to allow them to serve as their own control. The primary outcome measures in this study: to evaluate balance, we use the Berg Balance Scale, which is used in a lot of rehab settings and has been validated for people with brain injury. For mobility, they use the 6-minute walk test, which looks at how far you can walk in 6 minutes. And for occupational performance, they use the Canadian Occupational Performance Measure. And this is a measure that's really well known to occupational therapists, but it might not be as familiar outside our field. So I'm going to just spend a couple moments on this. So the way that this measure works, it's really great because it asks individuals to say, what occupations are you having trouble with right now? So it doesn't matter which ones you list, because we get standardized data because you rank your performance on each of those occupations, and then you rank your satisfaction with your performance. So if I were to be administered the Canadian Occupational Performance Measure, the COPM right now, I would say, well, I had ankle surgery about a year ago, and I'm still not back to my preferred occupations of hiking, of playing volleyball, and of running. Okay, so those are my occupations that are not quite going as well as I would like. And then I would rank my performance on each of those occupations. And then I'd say how satisfied I was with my performance. Now, let's say I did a yoga study or a yoga class for some time, and then I come back and I say, this is how I feel my performance and my satisfaction is. Even if everybody else in the yoga study had mentioned different occupations, we would all still have this standardized Likert scale score of our perceived performance and perceived satisfaction with our own occupations that are not going quite as well as we would like. So that was how we evaluated individuals' occupational performance and satisfaction. The participants that we were able to recruit were 9 with chronic brain injury. So all of these folks were at least 6 months post-injury, and they were recruited from the local community. I should point out now that Colorado State is not part of a med school. We don't have large hospitals here like you would see in bigger cities. So recruiting clinical populations is sometimes a little tricky. That said, we're also in a state where people do a lot of very risky activities on the weekends. People rock climb and bike and ski and hike, and they do all sorts of things. And so sometimes we get more brain injury because of some of those higher impact, higher risk activities that keep people here very fit. So overall, they're good things, but they can elicit a slightly higher incidence of brain injury, but not quite at the rate that you might see at a trauma one hospital center. So it's a little more tricky for us to find these folks, but we were working with a chronic population that did have some self-reported limitations in areas like balance. 7 of our participants were able to complete all of the time points, so baseline, pre-yoga, and post-yoga, but no one withdrew due to adverse effects from yoga, which is great news. You know, when we're thinking about ways to support people, rehabilitation strategies or medications or whatever, we're often thinking about, you know, what are the benefits, but also what are the potential costs. And so far in all of this body of work, we have not seen any adverse effects from yoga, which is fantastic. All right, so the 8 weeks of group yoga included sessions that lasted an hour that occurred twice a week. The sessions were led by a yoga instructor who was also an occupational therapist. This supported our ability to adapt yoga postures to support success by all of our participants. And this is actually one of our participants. It doesn't appear that she's in a group, but she was in a group. But this is her doing tree pose using a chair so that she could maintain her balance and still work on tree pose. So this is just one example of how yoga is adapted for folks that have physical limitations so that they can be successful in all of the postures. Some people remain seated for a lot of the yoga postures. The first couple weeks of group yoga tends to be completely seated. And then the really cool thing about this is for a lot of folks, especially for people that have had stroke or some sort of really traumatic injury, they get down to the floor during the yoga classes. And for a lot of them, the last time they were on the floor was when they had their stroke. And they were really scared and things, you know, they didn't know if they were going to be able to get help in time. And it's a really traumatic thing for them to have been on the floor and to go back to the floor in yoga in this supportive environment and to be able to breathe into that space and really be present on the floor with physical limitations has been really, really impactful in ways that we maybe haven't even begun to measure yet. But this is something that we've started to hear from our participants. And I'll say more about what we hear from our participants as I get to later studies. Some of our results are as you would expect. So just a quick note on the Berg balance scale, higher scores indicate better balance. So if you look at the first portion of this figure, side A, you can see the group level with standard deviations of baseline and pre-yoga. So there was no difference between baseline and pre-yoga. So we collapsed the scores across those. So people served as their own controls. There's no difference in that 8 weeks with no contact. So we collapsed across those scores and we said, this is their baseline and their pre-yoga score. And this is where they were post-yoga. This is statistically significant, but it's even more important that this is clinically significant, clinically meaningful, because that dotted line going across this figure indicates where people are at a fall risk, at a heightened fall risk. Scores above that threshold indicate that people are at much significantly less of a fall risk. So most of our people came in many of our people came in at a fall risk or close to being at that fall risk. And then most all of them exceeded that score that put them at the fall risk. So over in B, which you've probably started glancing at here, that's each of those 7 participants who completed all of the time points, and it allows us to see their individual performance. So the downside of having only 7 people is we can't generalize our results that much. The plus side of it is that we can actually see every single person really easily. So we can kind of look at people more individually, which is what we've plotted here and what I'll have plotted in the following results. And this work has actually been published in Complementary Therapies in Clinical Practice. So if you want more detail, you can look this one up. Our mobility results are similar, where we see significant group differences from baseline and pre-yoga to post-yoga. And then we also see an upward trajectory for most folks on the distance that they were able to walk over the 6-minute time period. You can see that that at least one person went down in their performance, but overall, most people had an upward trajectory here. I think any type of study where you're reporting group averages, which we typically do in research, you probably have most people that are improving if you've got significant results in the direction you expect. But every now and again, you have a person that, doesn't do quite as expected. And then we have our occupational performance results, where here we see the same kind of thing, significant differences between baseline and post-yoga. And then for the majority of folks, we do see that there's an improvement in how they rate their own occupational performance. And again, those are on their identified occupations that are meaningful and important to them. All right, I was just checking over to the chat to see if I had any questions. I don't see anything right now because I'm about to start to transition us into some other stuff. So yoga works. We see that yoga works. This protocol that Dr. Schmid has developed along with some of her collaborators and mentors, it works well. So we know what to do. We know to provide yoga. We know that it's working. We know that the adaptations are supporting people and that they're seeing these improvements and things that are really important to them. But the next question is how and why. So we really want to kind of understand what are the mechanisms that are supporting these changes that we're seeing time and time again, regardless of the population that we're providing yoga to. So this has been where the next line of work has gone. And it also reflects kind of what funding agencies are requesting. They want to know that interventions that you're creating are effective and that they're working, of course, but they also really want to understand why. So it's a way that we kind of bridge this basic science and this clinical science of saying, we really want to scientifically understand what's happening. And then we also want to see that it's providing support to the people that are in our studies, and then hopefully to people outside of our studies who benefit from this research. So because I'm a neuroscientist, I decided to add some neuroimaging methods to our study protocols. So we are using a couple different neuroimaging techniques. And again, we're looking at adults with chronic brain injury before and after a yoga intervention. So we had these really excited and lofty ideas, like we've got this protocol that works, so let's get some brain data. And, I hadn't done a ton of intervention work before. And so this has been a really great learning experience for me too, because we were just at the feasibility stage, the feasibility of getting these kinds of markers and the kinds of things that you have to consider and look for when you're doing this kind of work with a population, particularly a clinical population, and in an environment where it hasn't been done before. So to our knowledge, people haven't really done this tripart type of study before. So people have used neuroimaging in brain injury before. People have used yoga in brain injury before, but we haven't seen people using neuroimaging in brain injury before and after yoga before. So there's some novelty to this work, at least to our knowledge. And we could have missed other studies that have happened, especially if they've happened really recently. But this was a collaboration again with Dr. Schmid. And we then integrated Dr. Michael Thomas, who is an MRI expert. As I said, I like to use all the tools, but I don't always have all the expertise to execute them as well as I'd like. So I bring in other people who are really smarter than me, and can help with these kinds of applications. We had an adaptive yoga specialist join our team. She's been working for over 10 years with neurological populations to provide yoga in ways that are supportive for them and their performance. And we were able to integrate a few neuroscience students to this project as well. So here our objective was to use the yoga protocol and test the feasibility of acquiring neuroimaging data. And this time I had a much bigger role. So this time I had to acquire the grant funding, recruit the participants, select methods, reschedule all these activities around a global pandemic. Thank you, COVID. Made this a lot harder. Acquire pre and post intervention data and analyze and interpret the feasibility data. So this was a lot more of a role for me, but this has been really great. And as an early career researcher, it's been really great to apply some of the skills that I've been gaining into this intervention space. So again, our data collection was completed within university laboratories and classrooms. This study was a single arm intervention feasibility study with pre and post interventions completed 2 weeks before and after the intervention. So we didn't have that crossover piece where people served as their own control. And we were not masked to group assignment because people were only in one group. So I was assessing people. I knew they were going to yoga. Then I assessed them afterwards. I knew they had done yoga. So obviously that's a limitation of larger scale studies, but this was really just a feasibility study to see if we could do the things that we sought out to do. Again, we were recruiting adults with chronic brain injury from the local community, and the neuroimaging methods that we were primarily interested in having for this one was resting state functional magnetic resonance imaging, so resting state fMRI, to look at functional connectivity of neural networks. So we kept it somewhat simple. We were looking at brain activity at rest to look at those neural networks, to look at regions of the brain that are functionally connected to each other. So not our white matter tracks necessarily, but really what regions of the brain are co-activating at the same time. So that's what we're able to look at with resting state. And then we also use functional near infrared spectroscopy. And we acquired this was task dependent, so not at rest. This was during balance tasks. We adapted balance tasks from the Berg balance scale because we had seen positive outcomes with that measure. So we knew that that measure was validated for brain injury. We knew that the tasks in there were ones that people performed better on after yoga. So we actually paired it with functional near infrared spectroscopy. This is kind of my neuroimaging skill set that I am gaining expertise in, that I feel like is mine a little bit more than ours. So I'm going to spend just a little more time on this FNIRS methodology. The device that I have is a fully portable device, and it allows us to measure brain activity when people are doing functional tasks. So you can see that this person here is wearing a head cap with FNIRS, and the device that's acquiring the data is secured to this person's back. This device weighs 2.2 pounds or 900 grams. So it's not super heavy, it's pretty secure, and people can walk away from us while they're doing while we're getting brain activity. So the system has its own internet signal, and it wirelessly transmits all of the data to a laptop. And the laptop is one that we can use to also design what our stimuli are for the behavioral tasks, so that we can mark what's happening within our neuroimaging data. So we can say, okay, we want you to stand on one leg. So we know this, the participant knows this, and our data file know this is happening, and it can segment our data file into saying, this is what was happening at these time points. So for me, this is a really, really cool methodology, because as an OT who's really interested in functional things, and as a neuroscientist who wants to know how the brain is working, I get to pair these two things together. So I get really, really excited about this. What I typically do, and you don't need to be able to read this, but I just want to illustrate this, is I use a block design and I randomize my tasks. So we ended up using 6 tasks from the Berg balance scale, which was probably a few too many, but we started with quiet seated rest, and then we had them do a number of tasks that could be done for 30 seconds in theory. So some of the Berg balance scale items ask people to like turn around in a circle. We didn't want them to do that for 30 seconds. So we had them doing things like standing with their eyes open, standing with their eyes closed, standing on one foot, standing with one foot in front of the other, so that we could get an averaged brain response. So your best FNIRS methods typically are acquiring data for at least 20 to 30 seconds. They, like MRI, are dependent on a BOLD response, which is a blood oxygen level dependent response to brain activity. So you're waiting on blood flow. We're not directly measuring blood flow. We're actually measuring oxygen levels and oxygen metabolism at certain regions of the brain using near infrared light. I'm happy to say more about that when we get to the question and answer portion, but this is the type of device that I think is really cool and will give us a lot more data in the coming years than we've ever been able to get before because of the portability and the types of tasks that we're able to ask people to do. So again, this is a feasibility study. So our outcomes and our results were a little bit different than the first study, but we clearly defined our feasibility objectives and benchmarks and what we, and then we reported what we saw. So one of our main objectives and benchmarks was to recruit and retain participants for yoga intervention. We were successfully able to recruit 12, our goals were to recruit 12 and retain 80% of them. We were successful in recruiting 12 adults and retained 9 of the 12, so 75%. So we didn't quite meet our retention benchmark. We did have a benchmark as well about safely acquiring data. So we wanted to make sure that we could detect any contraindication for MRI during a screening process and have 0 instances of adverse events during data acquisition. And we were successful in both of those metrics. So our screening process did detect all contraindications, and in a clinical population at a school where there's not a lot of clinical work happening, this was really important to make sure our screening process was good for people who were healthy adults, which is who a lot of folks are studying, and then a clinical population, which was really great. And then again, we had 0 adverse events or falls. We wanted to be able to pre-process our resting state data and demonstrate acceptable quality indices. We wanted to, and this is getting quite technical, but I'll say a little bit about this, but achieve a time series quality index less than 3.5 MAD, which stands for a median absolute deviation in the data time point. So this is within subjects. It's just essentially saying we don't want there to be too much variability across time points in individual subjects. And we were able to see that we were getting 86.4% or 100% of consistency at those metrics that we wanted to see in our participant sample. So good quality of our resting state data. We also wanted to make sure that we could create a group-based connectivity map using the precentral gyrus seed. So the precentral gyrus is your primary motor cortex. And we wanted to see if by seeding that region in our analysis procedures, we were able to generate a motor map, a motor network map. And so we generated these for all of our participants, and we wanted to be able to visually inspect those maps and make sure that we saw graded rather than transitional areas of connection, graded and transitional areas of connection rather than random pixelation. So this was showing that there were regions of the brain that were connected to the motor cortex in the direction that we would expect. So other motor regions were also aligned with this motor connectivity map. So we were able to visually see that that was what we were generating. We also wanted to make sure that we could acquire FNIRS data during balance testing in people with balance limitations and mobility limitations. And again, we had a benchmark of 0 instances of adverse events or falls. And again, we had no incidents of adverse events or falls. We wanted to make sure that those were high quality data. And again, this is getting a little technical here, but we wanted to make sure that we were getting good light saturation in at least 80% of our participants. And that because they were moving, we wanted to be able to identify and remove the motion artifacts. So as they're standing on one leg and they're moving side to side, we're actually seeing that side to side movement in the data. And we wanted to make sure that our motion correction algorithms could actually detect and remove those data. And we were successful in doing that as well. And then finally, and this is a really good one, probably the most impactful one, is when we take the bird and we mess it up because we mess up the administration because we're doing it with simultaneous FNIRS, we want to make sure we can still detect that balance is improving. So we had to use a modified scoring system, a modified administration of this, and we still wanted to see statistically significant improvements, and we did. So we're really excited about that. So even when we had to adapt and move the administration of this, we were still able to see at a group level, people were getting better in their balance due to yoga. All right, so I know I went through that pretty quickly, but I want to make sure I have enough time to get to questions and some of the other stuff that we're doing now. So study 2 conclusions. Nearly all feasibility outcomes were achieved. As if you remember, we didn't have quite the retention that we had hoped to get, but we were close. Again, yoga improved balance with no adverse effects. And we might even be able to see detectable changes in brain activity following yoga. This is a really coarse and cursory possibility that some people are getting heightened brain activity to support their balance performance, but that really wasn't the goal of this study. This was a figure that we used in a grant application. So I think you will know what's coming next, to say, I think we can find something here. We have some preliminary evidence that things might be changing, and we've met our feasibility outcomes to say that we can get these things safely. So what we have happening now is a study called Evaluating Yoga Intervention-Induced Changes in Performance and Neurophysiology in Adults with Chronic Brain Injury. This is a news release that you do not need to read in depth, but what you need to know is that we got a $235,000 grant last June to continue this work. So that brings me to study 3. So study 3 status. All right, this isn't going to be multiple slides like the other ones were, because this one is ongoing. So for this study, we have, and partly because we have money, we were able to continue to expand our team, and we did so significantly. We added a postdoctoral research fellow. We have a biostatistician. We have experts in exercise science and in heart rate variability to ask a question of whether yoga is able to support changes in autonomic nervous system function. We have experts in structural connectivity acquisition and analysis, along with our functional connectivity expert. So Dr. Brzezinska does more structural connectivity. And if you remember from a few slides, we have Dr. Michael Thomas, who does more functional connectivity. So they're collaborating with us on this study to get some really great MRI data. And then we also have added an expert in qualitative data analysis and acquisition. So I think back in study 1, I was telling you, people are saying like, I'm feeling better. I'm feeling less stressed about being on the floor. We had a lady who hadn't been able to open her hand. She had such severe paresis in her right hand that her hand was in a clenched position, and she got her hand open in yoga 15 years after her stroke. These are the kinds of things that we're just not able to necessarily pick up with our quantitative measures, but we're able to pick them up and then get better information to refine our quantitative measures using qualitative acquisition and analysis. So Dr. Jen Weaver, who's an alumna of GW, she's actually helping us with qualitative data acquisition and analysis for this current study. It is a pilot randomized control trial, and it began this January. We recruited 12 adults who were randomized into group yoga or low impact exercise, which is metabolically matched to yoga. And we have acquired pre-intervention behavioral neuroimaging and heart rate variability data. Right now, participants are in week 4 of the yoga and low impact exercise classes. So week 4 of 8. And that's all I have to say about that. I thought I had one more bullet point. So overall, having done these studies, we've learned some stuff. We've learned some really important stuff. And these are in no particular order. So recruiting individuals, particularly in this community, is challenging. You can see that our numbers are small. We had hoped to have 24 people in the pilot RCT this January. We're actually doing it in 2 cohorts where we're having 24 in this spring semester and 24, we were hoping to have 24 in the fall semester, and we only reached 12. But that is where we are, and we're doing the best that we can to recruit people in this relatively small community. We have learned that our research would fail without student volunteers. It has been a blessing in disguise that we only have 12 people, because we need about 3 students per group to support the safety of those people in those classes. So in the fall, if we do get up to our 24 people that we're hoping to have 12 in each group, we're going to need at least 4 to 5 student volunteers in each of those groups to make sure that people can do the exercises and the yoga postures safely. Gold standard methods, for example, for getting heart rate variability data during yoga and the exercise classes doesn't always work well with clinical populations. We're learning that the watches are not easy to put on if you have any sort of upper extremity impairment. The chest straps are hard to get on to folks. And then it's really cognitively taxing to figure out how to pair the chest strap and the watch and all the things that we need to get this heart rate variability data using a gold standard method. We know that participant safety is more important than data quality. And every time that we have to make a choice between getting the data that we hope to get or maintaining participant safety and honestly, even their positive experience in our study, we always default to participant safety. And we've also found that finding the right journal for our work is tricky. So we have tried to publish our feasibility outcomes in neuroimaging journals that say that it's not quite a good neuroimaging fit, and rehab journals that say there's too much neuroimaging data. So we've been trying to find the right home for our feasibility study. So it says that manuscript is in prep. It's in prep after 2 rejections. So we're working on our perseverance skills actively for this feasibility study, and we will get it published. Our future aspirations, in addition to getting that silly paper published, is to make sense of our heterogeneous neuroimaging data. People with brain injury have very different brains, as we all know, and then trying to do group level or show group level changes is going to be quite tricky, and we know that is the case. We of course want to acquire larger scale funds to support multi-site studies and additional studies here, and we really want to continue to provide evidence for effective therapies for brain injury. So yoga is one of those things that really could be given to folks in these chronic phases, could be provided in the community with the right amount of support. And it would be great if people didn't have to pay out of pocket, or if they could get these things covered so that they could continue making gains long after they thought they were going to. It used to be that we told folks that, 6 months after your brain injury or stroke is when you can expect improvements and nothing beyond that. And, we had a woman open her hand after 15 years after her stroke. So we know that there's a need for services in this chronic population, and we're trying to provide the evidence that yoga could be one of those solutions. All right, so some acknowledgements here. So many people have contributed to this work. I tried to mention a number of them in my previous slides, but not all of them were named. And none of this work could have been done without Dr. Arlene Schmid. She's really the yoga expert. If she hadn't provided me those data back in 2018, 2019, none of this would have been happening. And she's been incredibly generous in her time, expertise, and data. Just a little bit about our funding. So our pilot and feasibility studies were supported by our colleges. So Colorado State University, but our College of Health and Human Sciences. They were early career investigator grants and human MRA pilot funds. Our current randomized control trial is supported by a Better Web Wearing Early Career Investigator Award. And my FNIR skill and my ability to do this kind of work is supported by the National Institute of Health through my Career Development Award. So I realize it says National Institutes of Healthy, National Institutes of Health Career Development Award, which has really given me the time and research effort to learn some things like FNIRS, and to be able to partner with interventionists and to really understand the population of brain injury from the more mild sports-related concussion groups all the way up to a more severe and chronic population. So with that, I would like to thank you so much for your attention and time today. I really appreciate having an audience to share this work, and I would love to take the next few minutes to answer any questions that you have.
Thank you so much. That was a really wonderful talk. Love to hear questions. Either feel free to unmute yourself or put it in the chat. And maybe I'll kick off a question. So I think you were getting at this in the third study. By the way, I really love the path that you led us on for the studies. I think that's great. With the 6-minute walk test, it looks like there was quite significant improvement in some, and maybe you're hypothesizing that there's some autonomic system dysregulation, which is why you added heart rate variability. Were you seeing signs of that in this population? Like, were they stopping the 6-minute walk test because of dizziness or because of other kinds of symptoms?
No, it has more to do actually with what we think yoga can do for everyone. So there have been some studies showing that yoga interventions can kind of balance out sympathetic and parasympathetic activity in healthy folks, making them a little more rest and digest than fight or flight. And we know that certain injuries, illnesses, and things can dysregulate that balance between parasympathetic and sympathetic. So even though, you know, some folks are certainly having shortness of breath and other things that are coming up, and dizziness, but I think it was more that we thought the intervention was possibly making some changes to the system that we hadn't measured before, and so we wanted to make sure that we could add that in.
See, yeah, that's fascinating. Because then with some patients that have had that are post-concussion, we use like the Buffalo treadmill protocol to try to kind of gradually increase the amount of exertion that they can do. And it seems like some types of yoga would do something similar to that too. So I wonder if that might be kind of an interesting intervention to parallel, or to have, with unlimited funds, to have another study where you match that, right?
Right, unlimited funds and better chest straps and better watch straps, so you can actually get them on people. Absolutely.
Exactly. Other questions that people have?
Oh, I think there's something in the chat. See if I can navigate over there. Maybe.
I don't see anything in the chat.
Okay. I just have an icon that there's one message, but I don't know if that was from earlier. Oh, okay. It's just a comment. And thank you for the comment. And I'm hoping that your dad's stroke recovery goes well. And he should do yoga. That's what we've learned.
Maybe I'll ask a two-part question next. So why FNIRS versus like EEG or other imaging? And then do you think you would have to establish a new MDC for Berg balance while using NIRS? Is it so different, from a sensory nervous system perspective that you might need a new MDC or new cutoffs?
Yeah, so that's a really great question. I know that EEG has there are a number of portable EEG systems that are commercially available, that people are using in research. I think it really just depends more on the question that you're trying to ask and answer. And I think EEG, so I use EEG for my concussion work. We see a lot more susceptibility to motion artifacts. We see a lot, like people grit their teeth or blink their eyes, and we get just huge spikes in the data. Those motion artifacts are a lot clearer and easier to remove from NIRS data, in my experience. So there's some methodological advantages to NIRS, and then it also, we're asking where. And if we were wanting to ask when, EEG would maybe be a little bit better of a technique for us to use. But yeah, we're really curious to see, particularly in people, I think it's really interesting in stroke, right? where if you're trying to balance on one leg or you're trying to do something with a contralateral limb where you've had neural damage, what do we see? What changes and where do we see those changes? Can we actually see the lesion hemisphere activate again, or are we seeing compensatory recruitment of other structures? So NEARS is going to allow us to kind of answer those kinds of questions. But your question about the Berg is actually really interesting because we kind of abandoned using the Berg as we did in study 2 for study 3, because we had so many people who couldn't stand on one leg at all. And so we're trying to get them to stand on one leg for 30 seconds. And I'm actually like holding them and to make sure that they don't fall. So I'm looking at their brain activity, but looking at their brain activity while they're getting physical support from me. I'm very comfortable doing this as an OT, but I'm not sure that it's the best way to get really good objective data, either neurally or physically. So we actually move this to just standing eyes open, standing eyes closed on and off a foam pad. And I think where our minimally clinical differences are going to reside maybe for us are the number of times that we have to fail tests, that they actually need support. So we've simplified the tests, and now if they're still needing support pre-yoga, but they don't need any support post-yoga, that might be analogous to a minimal clinical difference that we would see with the Berg. So it's not going to be that same direct translation where we have this nice cutoff score of 47 and we want them higher than that. But there might be some things that we're able to see that we're like, oh, I bet that means that you're less likely to fall when you get out of the car and you have to navigate over a curb, right? Because we can kind of see similar kind of movements. And to be able to say, like, this is how much your brain is working when you're stepping up onto this, and we're measuring your balance and how much sway on a balance pad. I think it's really cool that we've got both of those pieces of information. And I'm really hopeful that our team, being made up of neuroscientists and OTs, are able to think about this in both of those avenues.
That's great. That's wonderful. Seeing as it's the top of the hour and there's no more questions in the chat, I think we'll wrap up. So thank you so much for this great presentation. I'm really excited to see the outcomes of the third study and to follow your progress throughout future studies. So thank you so much for sharing this with us.
Yes, thank you for having me. I appreciate it.
And we hope to see you all at the next seminar series in 2 weeks. Have a great one.